your opinion, do you think suicide can be prevented if somebody really wants to kill themselves?
The short answer is no, unfortunately. I wish I could say it was yes, but I think the short answer is no, because I think if somebody really wants to commit suicide and they really want it, I mean, really want it, it's very different. I think they will do it.
Yeah.
Regardless of sometimes, unfortunately, what help is available. I feel like just sometimes actually some people have made their mind up already.
So hello viewers for A Psych for Sore Minds. We have a very special guest on today, a very experienced cognitive behavioural therapist by the name of Marilena. I will let her introduce herself. Welcome.
Hi, thank you, Dr. Das. So I'm Marilena Andreou, a CBT therapist. So that stands for Cognitive Behavioural Therapy. And I work privately in my private practice for Inspiring Minds Therapy, and that's based in London.
Great, thank you for coming on. So one of the things that we were discussing through email was about suicidal patients. I'm sure there must be quite one of the most difficult types of patients that you have to deal with. What are your thoughts on treating them in general?
Yes, I mean, particularly with sort of suicidal clients. I mean, I predominantly work with clients that have kind of depression or anxiety disorders. So the topic of suicide does come up. I mean, I've been working in kind of as a CBT therapist for kind of over 10 years now. So this topic kind of does come up quite a lot. And I feel like it's a really serious topic. And it needs to be treated very cautiously, very carefully in therapy when you have that kind of rapport with the client.
So I imagine it must be quite difficult for you if somebody brings up suicidal thoughts for the first time, especially if they're unexpected, because, correct me if I'm wrong, but I imagine there's a balance, right? Because on the one hand, you don't want to overreact and stop them from talking and opening up. But on the other hand, you need to be careful of the risk, because if there is a risk of them killing themselves, then you have to escalate. Is that the kind of thing you have to deal with?
Yes, absolutely. And it does come up in therapy, in sessions, working with mental health, you know, as you already kind of really know. You know, it comes up a lot, and suicidal ideation comes up so frequently, particularly with kind of depressed clients. Sometimes they're a bit reluctant to say it, particularly kind of when they first meet you, because you're kind of just building that rapport, especially during the first appointment, which tends to be an assessment. So when it does come up, you know, I take it very seriously, and they are aware that, you know, this is confidential, the therapy, but however, if there is any kind of risk to themselves or to others or from others, then it does need to be escalated. And, you know, we talk about that in the initial kind of introduction anyway, so they are aware of that.
Okay. And have there been many situations where you've had to do that, where you've had to, like, for example, arrange a mental health assessment or think about hospital admission?
Yes, particularly kind of previously, kind of when I first started out in kind of the mental health kind of field, I used to work kind of for, you know, kind of a big company. And, you know, kind of when I worked for that company, kind of the mental health services for that company, it was, you know, that has come up. You know, and I remember a particular case, and this is obviously confidential, you know, I'm not going to be naming any kind of names or demographic details and things like that. Sure. I remember a particular case where I worked at a GP surgery, and you know, this client actually was very depressed during the assessment, and basically said that they were, you know, they wanted to commit suicide.
Yeah.
But it felt very serious. It felt like this was not a fleeting thought at all. Yeah. So I had to kind of keep them there for as long as I could, and then kind of get the GP. I was quite fortunate actually, because I had that, working for a kind of multidisciplinary team at the time, I had that support right there. So I had the GP there, so I was able to kind of get the GP's attention and get the GP in, and kind of the GP kind of, you know, kind of did their part, and we kind of escalated it together and kind of worked as a team really. So that worked really well.
So the patient ended up going into hospital, presumably?
Yes.
And were they okay with that? They weren't too resistive?
They were okay with that.
Yeah.
At the time, and it was the better ending in the end, with that particular person, kind of they got the help they needed, and they were kind of feeling much better within themselves eventually.
So I've been involved in quite a few mental health assessments as giving his recommendations as one of the two psychiatrists. And I found with people that come in with suicidality, they tend to fall into one of two extreme camps. They're either really grateful and they want help, and they're just relieved that the responsibility has been taken out of their hands, so they don't have to live with these thoughts and also put their family through these thoughts, like thoughts of wanting to harm themselves, and they're just relieved that they're being removed from their lives and put into a safe situation. Or the opposite, or they find it really intrusive that they're trying to disclose something like suicidality, and they feel that we're kind of pouncing on top of them and just taking away their autonomy, really.
Yes, I know exactly what you mean, and I suppose it depends on the actual other problems they come with, right?
Yeah.
You know what I mean? Kind of, what other mental health condition they have. And it's not, usually kind of somebody who's suicidal has usually got some sort of underlying mental health condition, whether that be depression and anxiety of some sort, or just depression, or any other mental health condition, really. So I think it does depend on that as well.
Do you have, obviously I don't want you to name any specific clients, but broadly speaking, do you have situations where you're a bit worried about the risk, where you have somebody or even more than one person who doesn't present as acutely suicidal, so they're not so bad that you think they need to go into hospital on any one particular day, but you're just worried about them in the long term, that at some point they're going to do something very drastic? Does that happen to you?
Yes. I think particularly when I think of specific cases, what's coming to mind when you're saying that is actually those that self-harm.
Yeah.
And obviously that needs to be, from my perspective, kind of as a therapist's perspective, needs to be taken very seriously, but dealt with very carefully. Because if I am this point of contact for a client that is sort of actively self-harming, and this is not to say that actually self-harm always leads to wanting to commit suicide, but actually it needs to be taken into account, because it's kind of the function of the self-harm and what they're trying to do and why they're doing that. What do they actually want or don't want?
So as a therapist, what kind of things what do you do? How do you assess and how do you treat somebody that chronically self-harms? What kind of things do you think about or look at?
So I suppose with self-harm, it depends on the type of self-harm and the severity of it, the age group of the client. So for example, kind of, particularly kind of when, I work quite a lot at the moment also with kind of teenagers as well as adults, but, with teenagers, it's very much kind of obviously, understanding what they're doing and why they're doing it with self-harm. But actually, sometimes I sometimes find with teenagers, they don't always disclose it all. They sort of hide it, they try and conceal it because they're worried about what mum or dad are going to say. Because
and are they there because they want to be there, or are they there because mum and dad force them to, or is it a mixture?
Sometimes it's a mixture. So sometimes they want to be there because they know they want to kind of do well at school and all these things, but actually sometimes, so why are you here? What brings you here? I'm going to ask that question. Well, my mum wants me to have therapy. And it's very much that attitude, and that is very different. And sometimes kind of that kind of attitude can be kind of where they might conceal a lot and lie, and that creates all sorts of difficulties and barriers. But that's where kind of I guess I would work with the family as closely as possible to kind of get kind of so the client can get the best help.
And how do you break down those kind of barriers, or can you break down those barriers when you've got somebody that's just there, doesn't particularly want to be there, might be a bit of a stroppy teenager, might have mental health issues? Like, that sounds like a really challenging patient. Do you have like specific strategies, or do you just kind of do it?
It's a difficult one, I have to say. However, I guess I do pride myself in building a rapport with clients, particularly young clients. And I guess I do that in a way kind of when I kind of remember kind of what it was like going to school myself. Not that I had mental health problems myself or anything, but actually what it felt like to be at that age and the types of problems that they have and the difficulties in schools or outside of schools, kind of trying to kind of remind myself what it was like to be in their shoes once, and building that rapport and trying to build it as soon as possible, but actually at the same time kind of letting it happen quite naturally as well, like from session to session.
Okay.
And you know, just ensuring that they know that they can, you know, I'm someone that they can trust and they can tell me things, and you know, they're here because actually, you know, if they share certain things with me, then I'm there to help them, and
Okay.
not go. And once I've kind of, in some ways, got them on that kind of side, that angle of it, kind of they're more open.
Yeah. While you were saying that, Marilena, I was kind of thinking of the difference in the relationship of someone like yourself, a therapist, and a client, and a psychiatrist and a client, and it's very different. And I think that part of it is to do with the fact that when I've been seeing patients, especially who are suicidal, it's been in the context of detaining them, sometimes against their will. So I think they are quite reasonably, there's a degree of resentment. So you are somebody that, unless they're a teenager whose parents made them come, you're somebody who they've chosen to see on a regular basis, and they see you for a fixed period of time. Whereas when they see me, they're usually detained, they can't get out of hospital, and they don't really sort of get to pick and choose the length of their therapy or their treatment.
I can imagine how different that is actually, and what challenges that must face for you. That must be quite difficult.
Well, it's just sometimes it does feel like you could say that if people come in with something like an acute psychosis or acute mental health problem, acute mental health illness that's diagnosable and treatable, then you can give them medication, and it might take a few weeks to get there, but the chances are they will recover, the symptoms will improve. Whereas with suicidality, in the cases that I've seen, well, obviously they're quite disparate, but a lot of them, there's underlying problems that are there that can't really be resolved in a short hospital admission, you know, things like physical and sexual abuse from childhood. So it does feel like we're just containing them to decrease the risk until hopefully in a few weeks they're less risky.
Yeah.
So that, I guess, leads to the question, in your opinion, do you think suicide can be prevented if somebody really wants to kill themselves?
The short answer is no, unfortunately. I wish I could say it was yes, but I think the short answer is no, because I think if somebody really wants to commit suicide and they really want it, I mean, really want it, it's very different. I think they will do it.
Yeah.
Regardless of sometimes, unfortunately, what help is available.
Yeah.
I feel like just sometimes actually some people have made their mind up already.
Yeah.
With suicide.
So this is a bit morbid, but I have had the dubious pleasure of doing some civil court assessment. So that's when family members of people that have committed suicide within psychiatric wards are suing the NHS Trust for not keeping their relatives safe. And what's slightly depressing is that the same themes keep coming up over and over again. So they don't do a full risk assessment. The staff that work on the wards, they take the patient's reassurance at face value. So the patient will say, you know, I'm fine, I don't want to kill myself today. But the patient will be telling their family members, their partners in phone calls or during visits that they're, you know, on the edge of trying to take their lives. But the staff don't seem to care or even listen to what the patients say. So yeah, it's quite depressing that the same patterns keep happening.
Oh gosh, yes, I can imagine. That sounds quite difficult to kind of, I guess, have to kind of deal with that in the setting that you work in, because I would imagine actually you work in various different settings, unlike myself, where it's very much kind of the same clinic, whereas you're kind of in different settings, aren't you?
Yeah, so when I like do regular forensic psychiatry work, it tends to be within one ward for several months, but I also do like the odd civil or criminal case, which can be set in lots of different wards or prisons. Yeah. So how do you treat people in general who are either suicidal or depressed? Like what does long-term CBT look like for somebody like that?
Who's depressed and
depressed
or suicidal, right?
Yeah, depressed and or suicidal.
So I suppose with treating depression, it depends on if it's just depression or not. But usually if it's depression and let's say anxiety, then usually it would be kind of treating the depression first to try and get their mood increased enough to a certain level where then we can work on the other issues like anxiety. So with depression, you know, things like behavioral activation, kind of quite simply kind of helping them to get back into routines, doing things that could be a bit more pleasurable that they might have stopped, getting them out about a bit more, whether there's hobbies that they were doing, like exercise, doing that side of it. So that's very much the behavioural side of CBT.
Am I right in thinking that for that to work, you give them like almost homework tasks to do every week, and then you kind of check back to see how much they've done and how it's made them feel?
Absolutely, and that's a very important part of the CBT. What
Yeah.
they're doing in between is not just what they do in the sessions with myself.
Yeah.
And then what I was going to say is actually the other side of the CBT is the cognitive side. It's very much getting into kind of their thinking patterns, their negative thinking patterns, what kind of negative thoughts they're having about themselves or about the world, and trying to get them to make adaptations in that thinking pattern, and working even deep on a deeper level, like with what we call kind of core beliefs, which are kind of more deeper rooted, and trying to help them make changes in their whole belief system,
Yeah.
to help improve the way they feel about themselves,
That's
and to
quite a
reduce
task.
suicidal ideation and things.
Yeah, that's quite a task. And Marilena, I know you're very experienced. Do you ever find cases that you come across where you really struggle to change any of those things? Like, do you have a plan automatically, like a reflex reaction that comes into your mind, or do you still find that there's some patients that are a bit resistant or just won't react to what you're saying?
I mean, I usually have a plan, but actually I don't really know what you think about this, but there doesn't seem to be kind of like the textbook clients. You know, it's very different in real life. It's very different when you're treating someone than when you're studying, kind of when we're kind of at university and things.
Yeah.
The theory can be quite different to kind of what it's like to have the person in the room with you, because
Yeah.
actually a person tends to present with different problems. Like, even though they might come on the surface, they might come with, let's say for argument's sake, they come with just anger. They think it's just anger, but actually it's not. There's like depression or anxiety and things. So actually sometimes I find it, it can be obviously a challenge in itself when they're presenting with comorbidity and kind of various other sort of mental health problems. So it's trying to kind of find which one to work with first.
Yeah.
And then to follow with which other problem to kind of follow with, and which kind of pathway to take with it, really. But I sometimes, speak to the client, and sometimes I am guided by the client and what the client wants, really.
Yeah. Yeah. While you say that, I was just kind of thinking about the patients that I get that come in with depression, as opposed to something like psychosis and bipolar. I think one big difference for me is that the people who have very serious kind of psychotic illnesses, even though they lack insight, they're comfortable being in psychiatric wards to a degree. Like, they might not think they're necessarily unwell, but they're at least used to the environment, and they kind of, I'm trying to think how to put this into words, they fit into the environment, they fit in with each other. Whereas sometimes, not always, but sometimes when you get people that come in with just depression, because they are able to function well normally, so months or 3 months ago they were living a normal kind of high functioning life, compared to somebody with like chronic schizophrenia, it actually makes it harder for them to be on the ward, because they feel that they're surrounded by these people who are really unwell, people hearing voices and talking to themselves. So I guess there's an extra level of difficulty to try and convince them that they're in the right environment, or even to stay in the first place.
Yes, I see what you mean. But then what happens to those clients that, let's say, they're not convinced? In your experience, what happens?
So if they're a voluntary patient, then often they want to leave hospital. That happens relatively regularly if they come in not under section, because they get a bit kind of freaked out with the environment for the first couple of days. So then we have to make a really important decision about whether to allow them to leave, which obviously has its own risks, or detain them under the Mental Health Act. So either way, either we convince them to stay in if we don't think they're safe enough to leave, or we detain them. And then I think there's a bit of a lag before they actually get involved with therapy. So people similar to yourselves, we usually have a psychologist on the team, and it's once they actually start tying into therapy that they actually feel that there's something progressive happening on the ward. But it's a bit of a delay, so it might take several weeks for the psychologist to do their assessment and to actually start the therapy. So there's a good 3 or 4, maybe 5-week period where you just have to ask them to have a bit of faith in the system, I guess.
I see. That must be quite hard for you as a psychiatrist, but also the client.
Yeah, I think it's probably harder for the nursing staff, to be honest, because as a psychiatrist, we get to kind of swan in and out of the ward once a day or every couple of times a week, whereas the nurses have to kind of be there and take the brunt of all the emotions all the time. Yeah. I was going to change topics onto bullying, if that's all right with you, because that's one of the quite a major important issue, I think. Is that something you see, like victims of bullying within your patient group?
Unfortunately, yes. It seems to become even more and more apparent how much of bullying is happening. Because like I was saying before, kind of I work with quite a lot of young people as well, like a lot of sort of teenagers that are, I guess, still at school, sort of 14, 15-year-olds, that kind of age group, or 13-year-olds. And, it's something that happens. And I think it's very serious with bullying, because actually, because of the way kind of, I guess, the world is going kind of down the, there's very much kind of like social media and kind of like that side of things, how much that's kind of taken off for not just youngsters, adults, for a lot of people. So now what we tend to find, not only is there kind of obviously the physical bullying, there's kind of like cyberbullying as well. So I'm finding there's both of those. And actually with the physical bullying, it's a bit more obvious. But actually with cyberbullying, it's very subtle, and it can be very subtle.
And I imagine another issue is that the physical bullying, at least it stops. At least you get some respite when you finish at the school gates, when the kid goes home. But from my understanding with cyberbullying, it's just like constant. And if they want to have an online presence, which almost all kids do at that age, then there's just no avoiding it. It's really sad, actually. Really sad.
Exactly. So it just keeps going, and it keeps going. And I guess the question is, where does it stop? Because then when clients go and supposedly it gets escalated to, let's say, a teacher, parents know about it, a teacher knows about it. I mean, unfortunately, they don't always end up doing much about it when it's cyberbullying. It's difficult to contain it, to kind of identify who it is, because a lot of these things are anonymous as well, the way they can do it. There's not always a name there, so that presents difficulties in itself.
So what's the solution, or is there a solution, do you think?
Is there a solution? That's a difficult question, because you could say, actually, social media, maybe they shouldn't be on social media, for example, if it's coming from the social media side. Maybe the victim that's being bullied, shouldn't be on social media, and that would, kind of stop that from happening altogether. But actually, social media is a big part of kind of society now, and it's a difficult one to just stop, because if that person who's being bullied, all their friends are on social media, and actually there's kind of like a big community there, it's a shame for them to then miss out on that.
Because that will isolate them more and make them feel even more kind of disconnected from their peers, I guess.
Exactly.
So if that's not necessarily a good solution, is there any other solutions? I mean, I might be asking an impossible question here. Do you think teachers do enough? Do you think schools do enough?
From my experience, from working directly with clients that have either are currently being bullied or have historically been bullied, whenever I ask them the question, what has the school done? 90% of the time it has been not much, unfortunately. Yes, it's been voiced, we've told them, and they're looking into it, but unfortunately there doesn't seem to be kind of anything concrete where actually then, with physical bullying it's different, because I've heard of times where actually, the person that the bully actually gets excluded or something. There's a consequence, right? A serious consequence, which I really think there should be. Whereas when it's kind of like cyberbullying, it's different, and it's almost like, well, there hasn't been a consequence. It's been ongoing, and that's kind of had such a dent in their self-esteem, depression. I mean, you can imagine kind of the sort of problems that can come about from being bullied, trauma.
So it sounds like you're saying that the reason the schools aren't involved enough, not doing enough, it isn't because of apathy or a lack of care. It's because they actually don't know how to address it, and they don't know how to kind of monitor it. Is that fair?
Yeah. So that's what I believe anyway. Because I know there's been kind of various charities that have kind of been kind of commissioned to target bullying in schools, and I think they've been successful to a certain extent, but actually the problem is still existing, and it's ongoing. So I don't think enough. I still think enough isn't really being done. I think they could do more, the schools.
And do you think parents can do more, or do you think that's a bit unfair?
I think that's a bit unfair, because I think as a parent, I'm a parent myself, I've got 2 young children. I think I would do anything I could to prevent that from happening to, let's say, my own children. So I would imagine most parents might think in a similar way. I could be wrong, but
I'm also a parent. I've also got 2 young kids, and they're only 6 and 8, so there's no issues with, well, there's, apart from little playground tiffs, there's no major issues with bullying at the school. But it is every parent's nightmare, really, isn't it? And I think it's just really difficult to deal with, because obviously you want to step in and do something, but at the same time, I imagine that if you're too overprotective, then it's just going to add fuel to the bullies. Like, it's not cool to have your dad come around to school and like shout at the kids, is it? So
no, it's not. And actually, a lot of parents do want to do that, and they do want to kind of deal with it hands-on in that kind of direct way. But like you said, it's not cool, is it? And I suppose there's lots of other implications of trying to do it directly, isn't it? And then what kind of the school might think of that, they might be adverse to that as well. So it kind of creates even more layers to the issue, I think.
Yeah. So with your typical client that comes in who's a victim of bullying, what's the kind of circumstance or setup? Would they, again, does the kid want to be there generally, or is the kid kind of pushed there by the parents, or is it a bit of everything?
Usually I'd say they want to be there with that kind of presentation. Usually they want to be there because actually they're struggling, they're being bullied, and it's almost like, well, not much is being done. At least actually if they're in therapy, they kind of feel like, actually, this person is listening to me. This person is, they can't directly help with, stopping the bullying, but they can help me with my self-esteem, with my self-worth, because all those things come with someone that's being bullied or that has historically been bullied. It doesn't have to be kind of like actively bullied. And
to address those things like self-esteem and self-worth, is it the same kind of strategies as we were talking about before? Is it about like the cognitive and the behavioral aspects? So, core beliefs and also behavioral homework tasks as well?
Yes, I would say so. I always tend to find it's kind of a combined approach, not just kind of the cognitive side and, adapting the belief system. It's very much kind of that combined approach that comes together. Because actually, just by changing the belief system, if then one is still not going out much and socializing, then kind of we can't ignore the behavioral side, where if they're avoidant or all this other important side of being a person. Yeah.
Okay. It's very interesting. I'm going to put you on the spot a little bit now, so I'm going to ask you some questions that we haven't discussed before, but I think they'll be interesting for our viewers. Can you tell us, for anybody out there who's interested in becoming a cognitive behavioural therapist, can you tell us a couple of good things about your job, or a couple of areas that you enjoy, and maybe one con in your job, or one area that you find frustrating?
Well, there's never a dull day in the office, because doesn't feel like a day in the office, even though I work in a clinic. Because I would actually say kind of there's never a dull day, and you always get to meet such fascinating people. And I've always been fascinated by people, different types of people, different personalities, different presenting problems. So kind of obviously being a CBT therapist, kind of I get to meet so many different types of people, and it's and I get to kind of be there as part of their journey of hopefully recovery. We're trying to aim to some level of recovery or progress.
So it sounds like the perfect kind of perfect type of job for somebody who's just interested in people and interested in backstories and wanting to know people. And it sounds like you get a lot of job satisfaction as well.
Yes, I think that's one of the main reasons why I think I do the job, to get that job satisfaction and to feel like I've been part of their journey, their personal journey, and I've kind of helped in some way.
And what about the downsides? Are there any cons from your profession?
Are there any cons? Well, I suppose with every job there'll be something. Me personally, I love the kind of actual interactions, human interactions that I have, like my one-to-one work with clients kind of in the therapy. But the downside, I would say, the only downside is kind of the administrative side, which is different, because that's not actually kind of the clinic work. It's kind of like the the bits that the client might not see that you do, the in-between stuff, like the planning or the preparing or kind of whatever administrative tasks are kind of involved with in between seeing a client or
And I suppose, I don't know about your line of work, but in my line of work, certainly, because there's so much litigation and so much potential to be sued nowadays, you have to document everything way beyond what I think is helpful or clinically necessary.
Yes.
Just in case somebody says that you haven't done something, or, you know, we were talking about suicide assessments before, you know, you have to make sure you ask every single question every single time, because even if it wasn't your fault, if somewhere down the line somebody ends up hurting themselves, then there are going to be lawyers that will be rifling through all your medical notes looking for where you've missed something out or messed up.
Absolutely. And I suppose that the longer you worked in the mental health field, kind of you do kind of pick up some tricks and tips along the way. But I think me generally, I probably make maybe too many notes, probably for the reasons that you just said, to sort of almost like cover yourself just in case.
I think I could definitely relate to paperwork and bureaucracy being a major issue. So I think with my line of work, people hopefully enjoy my videos, etc. And I talk about the sexy bit, which is the bit where you make the conclusions about a patient's diagnosis and whether they're criminally responsible, whether they need hospital, and what kind of treatment. And that's the interesting bit. That's the bit I love. But to get there takes hours of just rooting through medical notes. So to make a diagnosis, to prove if somebody was psychotic at the time of offence, you have to look through witness statements, medical notes, CCTV footage, and it takes hours. Sometimes it takes days even to actually get there. And I think I don't talk about it that much because it's not that interesting to talk about. People don't want to hear it on the videos, but I spend more time looking through notes in a coffee shop than I do actually giving evidence in criminal trials. Absolutely,
I know what you mean, and particularly for me, kind of, I guess the whole preparing for, you know, you have a plan with a client, and the preparation of actually what is this plan, and, you know, kind of how are you going to kind of help them along this journey, kind of what are you going to be doing in the sessions, and planning ahead, kind of what kind of things that we are going to be working with and towards. And actually there's all sorts of, with CBT there are kind of various handouts and things that I prepare and I sort of give to them and things, and actually that in sessions they're just presented with them, which is great, you know, kind of there and then. But actually it's all in the in-between stuff that happens, isn't it, kind of in between, like you said, sessions, or kind of in between contacts with clients.
And do you have backup if you have particularly tricky cases? Do you have like supervision, or do you have like a mentor, or do you have colleagues that you discuss things with? And do you use them? Do you need to use them a lot?
Absolutely, supervision is crucial. I've always had supervision. It's always been kind of a requirement for a CBT therapist, and I think it's brilliant. I'm glad it is, because especially now, kind of now that I work for myself and I'm self-employed, and, you know, I work for my own private practice, you're not working as part of a team. It's just you and the client. So it's very different. So I have regular supervision, which helps with, you know, obviously bringing up kind of obviously cases and ensuring that you're working safely, and any issues that arise that could be kind of potentially to do with kind of risk elements and things. And I use supervision for kind of various things, and it's very important, and I enjoy supervision as well.
You do? Okay, that's good. I suppose it depends on how good your mentor is, really, isn't it? Sometimes they can be really reflective, you can talk to them, and sometimes they can just be there as a paperwork exercise. Just so that my viewers understand, when you talk about risk, do you mind just explaining what hypothetically might be some risky situations for your clients?
Okay, so I guess with risk, so you've got kind of different types of different elements of risk. So you've got some clients that come in and say, look, I'm having suicidal thoughts, and then you uncover that a bit more. Well, what do you mean? So some of them kind of wish to think that they didn't exist. There's that kind of side of it, and then there's others that kind of say things like, I don't want to be here, and things like that. And then there's others that might say things like, I don't want to be here, but I wouldn't actually harm myself. You know, there's various kind of like different layers of it. You know, but then some of them might give you a different part of the story, not the whole story. So it's almost like sometimes I'm playing a bit of detective to find out, what do you mean?
Yeah,
and then they kind of try and change the subject.
Exactly, you don't want to push too hard, because if you push too hard, then they might close off and they might not see you again.
And you're also trying to build a rapport with them at the same time, so it's it's kind of just treating that quite carefully.
Here's an interesting question, I think. Do you think, so when I look back at my training, we were taught how to do things like a risk assessment and how to do a psychiatric assessment, but we weren't taught the subtleties of exactly what we were talking about. So we weren't taught how to probe appropriately without pushing the client away, but with trying to get as much information as possible. Or, for example, if a client's really upset, suicidal, they've just been through some sort of trauma and they're crying, we're never really taught how to deal with that. You just you've got to use your instinct. So my question to you, Marilena, is, do you think you would, obviously you would have had a lot of training, did your training, were there any areas that were lacking, especially in terms of interpersonal, complicated scenarios in your training, do you think?
What you're saying is very true, because when I think back to my training, it was very much textbook training. So by that I mean very much kind of, if this is how we do an assessment, this is how we kind of, what questions we ask for risk assessment, and that's it. But actually it's very robotic. Yeah. It's almost like if you were to just read out those questions, it is robotic. And actually having the person in the room, I do not work that way. There's so much more involved than just reading out kind of these really kind of intrusive questions about how much they want to live and all these things. So it's very much, I guess, I've learned things along the way with building a rapport and not being so robotic, and
it's it's an art form, isn't it, to slip in the right inquiries and the right questions in the right manner. And I think for me, I imagine it'd be similar to you. When you very first start, it's really hard to contain in your head everything that you need to ask, and you're always I was nervous about missing things out, so I used to always have a template or write things down. But after you've done dozens or hundreds of them, it becomes so second nature that you don't need to, you're not distracted because you're not concentrated in the back of your mind of what you need to ask. It just comes in you've done it so many times, and it comes out naturally.
Exactly. It reminds me of driving. When you first learn to drive, it's kind of you kind of taught all these things that you need to do, but actually when you start learning to drive, it does feel very robotic. You've got so much to remember and you're really focusing and concentrating, but then after a while you pass your test and it does become second nature. It is very similar to this. It becomes second nature, and just finding your own way, your own way with the person in front of you, your own way with the way you're talking to them. And
that's a good analogy. I like that driving one. I'm gonna nick that.
That's fine. You can have it.
So changing topics a little bit, Marilena. Do you have any thoughts on whether it's necessary or not to disclose mental health issues to employers? So either for the individual themselves or for a professional like a psychiatrist or a CBT therapist. What are your thoughts on that?
Well, interestingly, this is a topic that's been coming up a lot in my sessions more recently, but just generally kind of historically as well. But more recently, it seems to be coming up. So, for example, I'll be in therapy with a client, and I tend to ask, does your employer know? Because I work with most of them are high functioning people. So by that, I mean high functioning anxiety or high functioning depression. So a lot of them are in employment or at school, whichever the circumstances is. So this does come up because I do ask the question, does your employer know? Because I'm curious as well, because sometimes actually people seek private therapists because they don't want to tell the employer, and they can get it outside of working hours. Yeah. So that you can kind of quite easily conceal that you're having therapy, because you don't have to take a regular time off each week from work. So it has been coming up because I've been asking the question, and a lot of the answers that I'm getting from clients is, no, I haven't told my employer. Oh, why not? When I ask that question, it tends to be, well, what will they think of me? I'll come across as being vulnerable. I might not get the promotion. And this kind of snowball effect that they have in their minds. And I would say it is in their minds, because it's very much, they've catastrophized it before they've even kind of really kind of taken it, like really considered it, kind of telling the employer or not.
Okay. So are you saying that everybody should disclose their mental health issues to their employers, do you think?
Not necessarily. I think it's very individual to the person. And I would never sort of say to a client, force that opinion in any way. It's very individual. And I suppose it depends on, I guess, the reasons that they have. And if it's not affecting their ability to work, then I guess in some ways they feel like actually, do you need to disclose everything to your employer about your mental health? Sometimes I do feel like, as much as I'm trying to break the stigma around mental health, you know, I do feel like that is an individual thing, and it's a very personal thing that you might not want to kind of tell your manager. That means HR will know, and it's not just one person that knows. It is kind of part of the management team. They would need to know. So I wouldn't necessarily be endorsing everyone to kind of declare everything about themselves, because it is quite a personal thing. What do you think?
I think it's a difficult one. I think it's a bit like driving with a DVLA. Like, the onus is put on the individual. Not necessarily, I'm not talking about mental health issues here. I'm talking about, say, something like epilepsy or having a stroke. The individual is given enough autonomy to make to themselves inform the DVLA, and as you'd expect, I'm sure many individuals don't do that. But I think as long as there isn't any risk, then I think it's up to the individual, and it might be good advice and it might be an integral part of the therapy. But for the reasons you've outlined themselves, for the stigma, for the potential embarrassment, I would understand if they didn't want to do it. The exception to that would be if there is a risk. So if they are, I don't know, if they're like for example, a school teacher, and they're in charge of vulnerable young children, and they have a mental illness which could make them extremely manic, and they've got a history of violence when they're manic, for example, that's something on the top of my head. If there is a risk issue, then it is very, very awkward. I think that I'd have to balance it up. And if I do think that there's a potential risk to other people, then I think I would have to really try and strongly convince the client to disclose it. And if not, then maybe even take steps beyond that and disclose it myself. But I think that'd be exceptional. I think that would be very, very rare, actually.
Yeah, I mean, I know exactly what you mean. I know what you mean. But also, while you were talking, I was kind of thinking of the times where actually an employee takes time off work, like with either stress or anxiety or depression, and then what do you say? What do you say to your employee? Why are you off sick? You know, you've gone to your doctor to get the sick note, but are you saying it's a physical condition, or what are you actually saying? Because then actually it could be seen as, come across as you're lying.
Yeah.
And you might be lying to the GP, and then obviously that gets communicated to your employer, and then you might get yourself into a bit of a mess.
Yeah. And I suppose it all boils down to the stigma of mental illness, doesn't it? So a lot of people don't understand how somebody who appears physically well can be struggling inside to the degree they can't turn up to work. So because they can't understand it, they make assumptions. They assume that person is just, being lazy or making it up.
Exactly. And like I said, kind of, I work with like quite high functioning people, and actually a lot of people, when they disclose it to even just a loved one or somebody that they're close to, like a friend or someone, a lot of the time they're surprised that they're struggling, because on the outside they look like them. They look like the same person.
Yeah.
It's not like a broken leg. You can see a broken leg, you can see it's in a cast, and they're limping, but actually with mental health it's internal.
Yeah.
So it's not always external like that.
And on top of that, it tends to vary, it tends to fluctuate. So almost all mental illnesses have periods of relapse and remission. And even when somebody's in a phase of relapse, they might have days where they can just kind of overcome it or battle it better than other days. So they might seem, even though they might not feel that well inside, they might seem better. So I think because people present differently on different days, that could be misinterpreted to somebody, exaggerating or malingering, because it's not that obvious to the outsider.
Absolutely. And it's also to do with the employer's knowledge of mental health, because actually there are, in some companies that I've found out about, actually, that they have this big push on mental health and supporting mental health, and they've got kind of like mental health, like first aiders type of roles that they've kind of developed that involves kind of specific training, and they're there to support anyone that might be suffering with mental health. So it does depend on the employer's level of awareness of mental health, and
absolutely.
what they are willing to do about it, and what if they are willing or not to help their employees.
Yeah, and I'd like to think that's getting better, because I think that the sort of mental health champion role is a relatively new concept. Like, that would have barely existed, say, 15, 20 years ago. So I don't know if it is going to improve or if it is, but I think time will tell. But in theory, because people are these roles are existing and people are becoming more aware, hopefully things are getting better for everybody.
Absolutely, I would hope so.
Before we finish, Marilena, a couple more questions. Can you tell us, have you got any advice for anybody who is a budding CBT therapist or who wants to be one? Any advice for them?
Any advice? Right. So I would say, if it's something that you really want to do and you really want to become a CBT therapist, I would say persevere, keep going, because it's a long road ahead of you. But actually, when you get to the other side, it is worth it. It's worth it. So it might involve starting with a bit of volunteer work and working your way up, working your way through various qualifications and exams and different mental health settings. But I would say keep going, you can do it. Okay,
that's very encouraging. And finally, do you mind telling us a little bit about where we can find out more about you, what you're working on, anything you want, either about social media or professional work, whatever you'd like to talk about and promote?
Yeah, I mean, yeah, so I suppose, like, for me, so I'm based in London. I work both at a clinic and I work remotely as well. So I suppose you don't have to live in London to be able to access my services. And my therapy, my private practice therapy is called Inspiring Minds Therapy. So I don't know if, I suppose we could put a link there.
Yeah, I'll put links to anything you want. Just give me them later and I'll make sure they're all at the bottom of the video.
Sounds good. But yeah, so you can obviously I am on kind of Instagram and I'll have a website. And actually on my website, I do have like quite a big blog section, which I talk about lots of mental health topics and top tips of how you can overcome certain mental health problems. And I also kind of work for, I write a mental health column for a magazine as well.
Okay, which magazine?
Sorry?
Which magazine?
Oh, 𝐘𝐨𝐲𝐻 magazine. It's a parenting magazine, actually. Oh. So it's kind of like talking about my side of it, talks about mental health for what parents can do or guardians to help their, child. But also what a child might be able to do or a young person. Top tips of helping them with, whatever problem it is. And it's very much kind of CBT approach based kind of tips that I sort of give, but quite kind of simple, straightforward things that people can kind of take from it, hopefully, and use. Okay, that's all really interesting. So my viewers, if you're interested in any of that, go and check out Marilena's links, which should all be in the description below. Thank you so much for being a guest. It was a pleasure talking to you. It's been really, really interesting. And thank you very much for having me.